Hello everyone, and welcome back to my channel. My name is Dr. Stephen Roth, and I'm a board-certified oral and maxillofacial pathologist. Today's video is the latest installment in my crazy case files, where I share how I was almost exposed to an airborne infectious disease, and it's probably not the one that you're expecting. But first, we have to get into that disclaimer, and that is that all opinions expressed in this video are mine and mine alone, and do not represent any organization that may employ me or that I may belong to, and that this video is for educational purposes only and should not serve as medical advice. Should you have any questions or concerns about your oral or systemic health, please see your nearest oral or systemic healthcare provider. And with that being said, let's get into today's video. This case begins with a woman in her 60s who emigrated from a South Asian nation approximately 5 years ago. She was experiencing significant gingival ulceration and mobility of a mandibular premolar. That mandibular premolar was extracted by her general dentist, and she was placed on a course of antibiotics. Over time, she wasn't healing, and her ulceration was becoming worse, so her dentist referred her to the emergency department. She was examined over the weekend by the general dental resident on call, who did a great job acquiring these pictures. These pictures show ulcerated erythematous gingiva, and the ulceration of that gingiva extends onto the buccal mucosa. You can also see ulcerated excess tissue formation on the lingual side of the ridge. A panoramic radiograph was also obtained, but it didn't provide much insight. The patient was referred to our service to be examined after the weekend. However, a few days later, the patient began to experience shortness of breath and was coughing. The patient reported back to the emergency department and tested positive for SARS-CoV-2. The patient was admitted to the COVID unit in our hospital, at which time I was paged to examine the patient. I obtained this picture, which I'll admit isn't nearly as nice as the resident's picture, but it's hard to take a good picture when you're in a full bunny suit and hazmat uniform, essentially, because that's the airborne precaution attire. I was obviously very concerned about this lesion, and the top of the differential for a non-healing, granular, friable, or fragile ulcer like this one is cancer. I was worried that this patient may have some sort of malignancy of their gingiva. I consulted with the infectious disease team at the time that was managing the patient's COVID, and the patient was improving, but still on supplemental oxygen. We decided to wait until the patient was on room air before bringing her down to the clinic for a biopsy. A few days later, the patient's COVID symptoms have improved, and she was able to breathe on her own. She was testing negative for COVID at that point. We brought her down to the clinic for an incisional biopsy. Now, this is where things get interesting. While I was expecting malignancy, instead we saw granulomas under the microscope. Granulomas are a specific type of inflammation that is composed of histiocytes or macrophages in a tight ball with giant cells mixed in. We see this type of inflammation in a wide variety of infectious and inflammatory or autoimmune conditions. If you remember my essential differential video for a non-healing ulcer, you'll remember that in addition to cancer, we think less commonly about specific fungal infection and tuberculosis in this scenario. These diagnoses are also of concern when we see granulomas. So we performed a gram methionine silver, or GMS stain for fungus, which was negative, and an AFB, or acid-fast bacilli stain for TB, which was also negative. Even though the stains were negative, I was still suspicious, especially knowing that the patient lived in an endemic area for these infectious conditions for most of her life. I went to deliver the diagnosis to the patient on the floor and inquired about any history of a fungal infection or TB, which the patient adamantly and repeatedly denied. Still suspicious, I pulled the PA on the floor aside and suggested that they perform TB testing for this patient. We also sent our tissue block from the biopsy to the Mayo Clinic to perform PCR for TB organisms. The first test to come back, the quantiferon. Quantiferon is a blood test that tests for TB. This test yielded the least satisfying result in all of medicine, which is indeterminate. In addition to the quantiferon blood test, there are additional TB tests that are routinely performed using the patient's sputum. This test is performed by having the patient cough into 3 different containers. A screening test is performed on each container by scooping a little bit of that cough product onto a slide and using AFB, the same stain we used on the tissue, to see if any bacteria are readily observed. The containers are then left for a few days to see if any bacteria grow. The initial sputum screening on the 3 containers in this patient was negative, and no bacteria were seen on the AFB stained smear. The patient, having fully recovered from her COVID-19, was discharged and sent home. So I eagerly awaited the results of our Mayo Clinic test on our biopsy tissue block. About a week later, we got our results. Negative. I chalk this case up as a mystery. Maybe we'd never really know what was going on with this woman. I emailed the infectious disease attending, who I worked very closely with on the case, with the results, and that's when I got this email back. Hi, actually, her sputum just showed growth of AFB. 2 of the 3 cultures from the patient's sputum grew TB microorganisms. A DNA probe confirmed that this acid-fast mycobacterium was truly Mycobacterium tuberculosis, the causative bacteria in TB. Infectious disease immediately called the patient and initiated RIPE therapy. RIPE is an acronym that stands for all of the medications that they use. They have to use multiple medications to make sure that they effectively treat the bacteria and to prevent bacterial resistance. RIPE consists of rifampin, isoniazid, pyrazinamide, and ethambutol. When delivering the diagnosis, the patient's daughter stated, "Oh yeah, I think she had that when she lived in our home country." The patient experienced complete resolution of her gingival lesions within 1 month of starting her RIPE therapy. A quick word on TB. Tuberculosis is caused by Mycobacterium tuberculosis bacteria. There are many parts of the world that have difficulty containing and treating this bacteria. And prior to modern day antibiotic regimens, this disease was once known as consumption and was often fatal. In the United States, cases of TB are reported to the county health department. Fortunately, I was protected because I was already on airborne precautions because the patient had known COVID. So not only was I protecting myself from the patient's known COVID, I was unknowingly protecting myself from TB as well. Oral lesions in TB are extremely uncommon. There is debate as to why they even happen. One thought is that the bacteria travel through the bloodstream from the lungs and make a home in the oral cavity. The other thought is that when the patient coughs, the bacteria in the cough invade and occupy the oral mucosa. Either way, this is an extremely interesting case and one that I will probably never see again in my career. If you want to see more of these interesting, rare cases, check out my other crazy case file videos. And while you're at it, you should subscribe so that you don't miss any future videos just like this one. Thanks again for watching, and be well.